All right. Good morning. Thanks everyone for joining, or good evening, good afternoon, wherever you may be joining us from. So Shwani outlined the focus of today's webinar will be on different aspects of MetALD to really help us understand the recent research, the epidemiology, management, really provide a comprehensive assessment of MetALD, which, as all of us know, is a relatively new nomenclature and something that is very important for us to really understand. So today, the first 15 minutes or so, I'll be talking briefly on epi, mostly definition, prevalence, diagnosis, and a little bit on prognosis of MetALD. So objectives will be to review the updated nomenclature and definition of MetALD. We'll describe updates in the epidemiology of SLD in general, but with the specific focus on where MetALD places in that spectrum. And then following that, we'll touch on understanding the differences in risk of cirrhosis and HCC among patients with MetALD. This is a figure that hopefully all of you have seen or are familiar with. It's the nomenclature for which we define steatotic liver disease. And as you can see here, steatotic liver disease really spans a spectrum of diagnoses from those with predominantly metabolic dysfunction-associated liver disease, which we term here MASLD, all the way till on the other end of the spectrum, a predominant alcohol-associated liver disease and some other sort of smaller populations of cryptogenic or specific etiologies. But today's focus will really be on MetALD. And MetALD, as hopefully you'll see and will highlight throughout the session, is tricky because really this is trying to incorporate both aspects of metabolic as well as alcohol, and to some degree try to understand those individuals that have really combinations of both that are contributing to their underlying liver disease. And you can imagine that sometimes that may be very difficult to highlight, especially when trying to assess what is the predominant contributor when someone has both of these risk factors. So we're going to touch a little bit on that. First, I think it's important to understand, again, this is data or flow diagrams and definitions you have seen before. It really helps us understand how we identify, how we categorize, and what are the factors we think about when naming or identifying individuals with steatotic liver disease. As you can see here on the table on the right side of the screen, these are the so-called cardiometabolic risk factors that we think about, including weight or body mass index, insulin resistance, blood pressure, lipids, etc. And these help us first identify the concurrent metabolic factors that are present contributing to steatotic liver disease. Then, as you see on the flow chart in the bottom part, to distinguish between these different so-called disease states, we think about what are the predominant contributors, and then what is the component of alcohol. And this is just a different way to sort of frame the previous slides to think about these distinct disease states. But as you can imagine, people's metabolic features and alcohol change over time. So I think one key take home is that these disease states, while we think of them in distinct boxes, in reality, it's actually very fluid, and people can transition back and forth between these different disease states. And that's an important concept to take home because those changes reflect, one, how we refer or categorize them, but more importantly, as I'll show in the subsequent slides, it may reflect differences in prognosis and risk of disease progression. These are data you've seen. Just thinking about MASLD in general, we know, and hopefully you've recognized already, that these metabolic risk factors are important contributors to developing steatotic liver disease and MASLD. But I put this here because it's also important to recognize that these same metabolic factors are also important in contributing to MetALD. These are data published not too long ago looking at the prevalence of MetALD, and we see that almost a third of the world population, with some variation by geographic regions, are affected. It's important to recognize this because, again, people shift and the definitions are fluid, and patients with MetALD do have an underlying background of metabolic risk factors. Alcohol is also important. These are data from a few years ago looking at both NHANES as well as mortality data to look at trends in alcohol. Alcohol, as all of us know, are increasing in prevalence. But it's also important to think about in the context of MetALD, because as I mentioned, MetALD is really a convergence of both MASLD and ALD. And so as we think about both of these disease states increasing, of course, we would expect that MetALD prevalence is also a major clinical burden and also is expected to increase as we see both alcohol use and MASLD prevalence increase. This is another data looking at more global prevalence of alcohol. And again, you can see alcohol-related liver disease is another important global burden. Sure, there are different geographic differences, and that may reflect differences in alcohol policies or alcohol drinking behaviors. But again, the importance here is to recognize that both mass alcohol-related liver disease and hence MetALD are major contributors to both liver disease prevalence as well as liver disease-related mortality globally. We saw during the pandemic that there were dramatic increases in alcohol use. This is one modeling data that showed the impact of increases in alcohol consumption during the pandemic. And you see here that the model showed that just 1 year increase in alcohol contributes to significantly increased alcohol-related deaths, decomp cirrhosis, HCC, and disability-adjusted life years. Unfortunately, as many of us have seen and our literature has showed, this 1 year increase was not limited to just during the early days of the pandemic, and we continue to see persistently elevated levels of alcohol use, which combined with underlying cardiometabolic risk factors is driving and fueling a increase in prevalence of MetALD that is really under-recognized, in my opinion. What are some of the challenges in trying to identify MetALD? As we alluded to, alcohol use is not routinely or systematically assessed, even in real-world practice. If you think through your own clinic, think about how often you do very detailed assessment of alcohol. I admit myself, I don't do that as much as I should. This is compounded by stigma, underreporting, and so sometimes just discomfort with assessment in certain settings. When we think about the data that's being generated on MetALD, there's also similar challenges in evaluating alcohol use, particularly ICD-9 and 10 codes, which a lot of these claims-based or large data sets use, are lacking in sensitivity and specificity in capturing alcohol use. Sure, we can capture things like alcohol-related cirrhosis, decompensation, or maybe alcohol use disorder, but trying to capture more granular or even mild or moderate levels of alcohol are sometimes very challenging and maybe even impossible in some of these large data sets. And then finally, as I alluded to a little bit earlier, we need to remember that alcohol use is not static. It's dynamic and changes over time. If you think about several of your patients that may have had alcohol use disorder, you can probably identify a few or several that have changed their alcohol use patterns over time. And that's an important concept because most of the distinction across the SLD spectrum sure relies on cardiometabolic factors, but a lot of it is driven by changes in alcohol use. And so we need to recognize and remember that alcohol use is dynamic, and hence the disease states between MASLD MetALD, and alcohol-related liver disease is also dynamic and changes over time. And these changes ultimately affect an individual's risk of disease progression and prognosis. This is a relatively recent, last year, paper in the US using the NHANES data. And they tried to categorize the different subtypes of steatotic liver disease. And so you can see here some key points. Number one, about 38% of the population had steatotic liver disease based on their definitions. So 38%, almost 4 in 10. The other key point to take away here are the boxes on the bottom. So the study subcategorize steatotic liver disease into the different subtypes. As you can see here, the study showed that predominant contributor to SLD was MASLD, followed by 2.5, 2.6% MetALD, and a much smaller proportion with ALD. However, we should take these numbers with caution because, as we alluded to earlier, some of these databases have limitations in capturing and assessing alcohol use to accurately categorize MetALD, and NHANES, like many other databases, are static, meaning they capture alcohol use or a patient's demographics at a certain point in time, and we should acknowledge that these disease states can change, thus contributing to fluctuations in the actual prevalence of these different disease states. Not going to focus too much on here, but this was the study looked at the prevalence of fibrosis using different liver stiffness measurements across the different disease states. But the key point here is the study highlighted that MetALD was a relatively smaller contribution, at least in this US-based data set. This is another study using the same data set published actually same year in hepatology. And again, they tried to characterize prevalence of different subtypes of steatotic liver disease. And as expected, because they used the same data set, the prevalences were very similar. You can see here on the top left, figure A, that despite stratifying by age subtypes, MetALD still represented only about 2 to 3% of the total SLD. When they stratified by different other demographics like race, ethnicity in figure C, sex in figure B, as well as by liver stiffness, there did not seem to be major changes. And again, MetALD, at least in this data set, still represented a much smaller proportion compared to MASLD. Then we look to other countries. So this is one national health screening database that I wanted to highlight from Korea. Similar, I think, to NHANES, they used, this one included about 350,000 individuals, age 47 to 86. They defined steatotic liver disease using the fatty liver index. And again, their goal was to try to identify, one, the prevalence of SLD, which you see in the figure was 44%, and then the subtypes. So again, we see predominantly in this cohort, it was mostly MASLD with a smaller proportion of MetALD or ALD. But we do see that the prevalence of MetALD was slightly higher, about 3 times higher than what was seen in the NHANES. So some variation here, but still we can see that the predominant contributed SLD in the Korean population based on this data set was still MASLD. Then I'm going to go to some more recent data. This is a very nice data coming out of Denmark, prospective cohort study of over 1,000 patients to look at a few key features of steatotic liver disease. One, they looked at the overall prevalence. And then interestingly, they captured dynamic changes in disease states. So this is a very cool study where they looked at over time, how many of these individuals actually change from one disease state to another. And as you can see here, patients started off with these disease states on the left, and then the disease states on the right are the disease states for which they transitioned. Overall, they found that almost 40%, so almost 40% of individuals change or transition their disease states. And of those with MetALD or ALD, 60% transition. So it's a very important concept for us to recognize that these disease states can change. And then finally, these are some data in the US looking at a veterans population that highlight a similar findings. When we looked at the totality of the SLD cohort, we observed that a much higher proportion had MetALD here, 35%. And here, it's important to acknowledge that we also did not have very granular alcohol data, but we based it on Audit C. And over 95% of veterans have at least one documented Audit C in their chart to be extracted. So very important limitation, but still it suggests that perhaps alcohol assessments and MetALD in general may be under-recognized in larger populations. Why is that important? Well, it's important because these different disease states have different risks. So this is very nice data from Taiwan looking at differences in risk of cirrhosis and HCC based on SLD subtype. You can see here the different lines represent different subtypes, and across both cirrhosis and HCC, it shows that alcohol-related subtypes have the highest risk, and then followed by MetALD. So emphasizing that there is a difference in disease risk between different subtypes, and MetALD has a much higher risk of cirrhosis and HCC compared to MASLD, and hence the importance of recognizing this distinct disease subtype. And then finally, these are preliminary data from the VA cohort where we looked at changes in disease state. So we looked at how changes in disease states affect, or a difference in subtype affect disease risk, very similar to the Taiwan population. And we saw very similar findings. Again, highest risk was in alcohol. But interestingly, in this large US cohort, we saw a flip. We saw that actually the highest risk of cirrhosis was in MASLD, and MetALD has a slightly lower risk of cirrhosis. And then what happens when these change over time? As we mentioned, we know that alcohol use changes over time, and hence it's important to understand how this affects disease risk. And I know we're short on time, so I'll just briefly mention that this study showed that if you change your alcohol use over time, it does lead to differences in risk of cirrhosis. And I highlight on the bottom, individuals who have increased their alcohol use in the middle box here over time have a significantly higher risk of developing cirrhosis. In contrast, if you decrease your alcohol use, it leads to a drop in your cirrhosis risk. So really important to highlight that these are modifiable changes and can change your long-term risk of cirrhosis through counseling and linkage to resources. And then again, this is just highlighting same thing in figures, that if you change your alcohol and transition your disease states, it does ultimately alter not just your risk of cirrhosis, but also your risk of HCC. So in summary, I think the goals were to highlight that prevalence of MetALD is likely higher than previous estimates due to challenges and limitations with accurate alcohol use assessment, and hence the importance of routine assessment and documentation of alcohol use. It's important for us to understand alcohol use is dynamic, and hence the SLD subtypes themselves are dynamic and can change with time. It's unclear if MetALD is consistently associated with higher risk of cirrhosis and HCC. We see conflicting data depending on different subtypes of populations, but this is important to recognize and deserves more research. Either way, I think it's clear that increasing alcohol use among both MASLD and MetALD are associated with higher risk of cirrhosis and HCC, further emphasizing the importance of assessing for and ensuring that these individuals are linked to appropriate alcohol use resources. Thank you.